We'll move to the session of cholestasis. May I call Professor Fathallah, Professor Mahmoud Anis, Professor Brehan Sayed to chair this session with me. The first speaker is Dr. Sameh Lashin from Alexandria University, who will give a resume about cholestatic jaundice. Professor Sameh.
Good evening.
Go ahead, Sameh.
Okay.
اعمل شير سكرين وهات لنا السلايدز.
It's okay.
Yeah.
First of all, I'd like to thank my dear professors and dear mentors, Professor Yusri Tahir and Professor Ahmed Zeid, for inviting me to present this talk. Now we will go back to some basic informations. I'm presenting a talk about the approach to cholestatic jaundice. Cholestasis, by definition, is an impairment in the bile formation and or bile flow. And the word jaundice is clinically due to the yellow discoloration of the skin and mucous membranes due to an elevation of serum bilirubin, while hyperbilirubinemia is the biochemical reflection of jaundice. To present this point, we have to revise some basic data about the bilirubin metabolism. In short, the bilirubin metabolism starts with the generation of bilirubin inside the intravascular compartment through the intravascular hemolysis. It will start with unconjugated bilirubin, which will be translocated into the hepatocytes in unconjugated form, then will be conjugated and excreted into the biliary tree. Through the biliary tree, it will be released into the small intestine. About 90% of this conjugated form will be released with feces, while 10% will be back again into the circulation through the enterohepatic recirculation. Jaundice can be classified according to the source of its formation. It may be due to increased production, like increased hemolysis, or it may be due to derangement in the liver handling of bilirubin inside the hepatocytes, either diminished uptake or conjugation or release into the biliary tree, or it may be due to biliary obstruction, where there is no release of bilirubin into the biliary tract and to the intestine. The increased production usually is due to some causes resulting in increased intravascular or extravascular hemolysis, and all these causes are not classified under cholestatic jaundice. While the cholestatic jaundice can be due to derangement in the liver handling, and it's further subclassified into hepatocellular cholestasis. That is to say, the main pathology here is due to some sort of injury to the hepatocyte itself, and this includes a very large list of causes, starting from sepsis, endotoxemia, drug-induced viral hepatitis, or some congenital disorders or genetic disorders, or maybe due to cholangiocellular cholestasis. That is to say, the main pathology here is due to the injury affecting the cholangiocytes, such as primary biliary cholangitis, the primary sclerosing cholangitis, the overlap syndrome, the IgG4 associated disease, and other causes. Lastly, the biliary obstruction, which can be due to intraluminal or neural causes or external compression of the large biliary ducts. How to approach a patient with cholestasis or patient with jaundice? To reach the cause of jaundice, we have to be aware of the list of causes initially. Then a proper history taking is a very essential point or step in the approach to this patient. The common symptoms are fatigue and pruritus, which are very common and usually antedate jaundice. The onset, the course of jaundice, the chronic, that is to say, the pathology or the disease is present for more than 6 months, usually point to an intrahepatic rather than extrahepatic cholestasis, the color of urine and stool, the associated manifestations, the past medical history or drug history or family history. All these points are very essential due to their impact on the differential diagnosis list, which will guide you to the further investigation later on. Clinical examination also is an important step to search for signs like signs of chronic liver disease, liver enlargement, lymphadenopathy, the presence of Murphy signs or signs of sepsis, and so on. Now, what is the next step to reach the final diagnosis? First of all, we have to exclude the prehepatic causes of jaundice, the presence of indirect hyperbilirubinemia with otherwise normal liver profile and no evidence of hemolysis suggests Gilbert's disease. The laboratory approach to a patient with cholestatic jaundice. In asymptomatic patients, the early markers include increase in both serum alkaline phosphatase and GGT. This will be followed by conjugated hyperbilirubinemia at more advanced stage. The next step, it will be the differentiation between intrahepatic versus extrahepatic cholestasis. Actually, some data from the history or clinical examination may guide you to reach the most probable source of this jaundice or cholestasis. But the most important next step should be the evaluation of the biliary tract by biliary imaging. The gold standard of initial assessment is the ultrasound examination, where it can show us the biliary dilatation like this photo. It may show even the cause of biliary obstruction like presence of a stone in a dilated common bile duct. The ultrasound can detect the cause and the level of obstruction in most of cases, but sometimes the etiology may be unclear, especially in the distal pathologies where the distal CVD is behind the duodenum and it couldn't be seen by the gases of the intestine. So the next step should be the MRCP. The MRCP can show us the site of narrowing like this structure. It can diagnose a distal stricture or distal narrowing in the common bile duct. It can show us presence of stone inside a markedly dilated common bile duct. The endoscopic ultrasound has recently gained a popular interest in the diagnosis of biliary or pancreatic pathologies. It can be both diagnostic and therapeutic, like in these photos. Here, this is a stone in markedly dilated common bile duct, and here we can do drainage of dilated biliary tract, gastric or transduodenal approach. The ERCP, once the extrahepatic cholestasis is diagnosed, the role of ERCP as a diagnostic or therapeutic tool comes. It can diagnose the biliary obstruction. We can remove stone. We can insert metallic or plastic stent. However, it's an intervention which is not without a risk. It can lead to post-ERCP pancreatitis, bleeding, or perforations. So the EOS is considered a better solution when available to avoid the ERCP complication, especially in lack of expertise. As regards the intrahepatic cholestasis, after exclusion of extrahepatic causes, we will turn into another list of investigations to reach the etiology of this intrahepatic cholestasis. The complete liver profile, including bilirubin, direct and total liver enzymes, serum albumin, alkaline phosphatase, and GGT. This will direct the attention to hepatocellular or cholangiocellular cause of intrahepatic cholestasis. If the lab derangement is mainly hepatocellular, where the ALT will be disproportionately elevated rather than alkaline phosphatase, a full screen of causes of liver disease is mandatory. If the alkaline phosphatase is more elevated in disproportionate manner to the ALT, the cholangiocellular etiology here is suspected. And the next step should be the searching for primary biliary cholangitis by requesting the antimitochondrial antibody or the BBC specific ANA. If this is negative, we can suspect either other cause or serology negative BBC. We may need to reach the final tool, which is liver biopsy. Actually, liver biopsy will classify our finding into three forms: either disorders involving the bile duct for typical biliary lesion like AMA negative BBC or isolated small duct BSC or sarcoidosis, or the disorder will not involve the bile duct like storage or infiltrative disorders, the hepatic granulomas, cirrhosis, or the hepatocellular cholestasis with only minimal histologic abnormalities like some benign recurrent intrahepatic cholestasis or estrogen or anabolic steroid effect or patient on TPN. This is the suggested flowchart by the EASL guidelines 2017 for approaching a patient with chronic cholestasis. Now I will give short notes about some common causes of cholestasis. We'll start with the IgG4 disease. It's an autoimmune disorder Actually, it is not a single disease. It's an accumulation of multiple affection in different organs like the lung, the dacryocyalidinitis, type 1 pancreatitis. It has its own diagnostic criteria, which should involve it with some organ affection, with the presence of serum IgG4 elevated, and tissue diagnosis of IgG4 positive plasma cells. It's associated with some other disorder like retroperitoneal fibrosis, mediastinal fibrosis, and so on. And its treatment usually the immune suppression corticosteroid. Primary biliary cholangitis, in 50 to 60% of patients, they are asymptomatic. Fatigue and pruritus are the early complaint. Antimitochondrial antibody is positive in nearly 90% of patients, and 10% will be AMA negative VDC. The ANA agonist, the nuclear SP100 and the glycoprotein 210 protein is positive, and if it's detected, it provides some prognostic values on the long run, in addition to the response to treatment in the first year. Usually there is high IgM, and it may be overlapped with autoimmune hepatitis. Liver biopsy in some serology negative cases is needed, will show us the bile duct damage, bile duct proliferation with the granuloma formation, and the treatment depends on the deoxycholic acid, which provides some survival benefits. The primary sclerosing cholangitis, from its name, it's a primary idiopathic disorder with hardening of the tissues of the bile duct due to inflammatory reaction. Usually, it's associated with other disorders like inflammatory bowel disease, especially ulcerative colitis, some sort of hypothyroidism, autoimmune hepatitis, autoimmune hemolytic anemias, type 1 diabetes, and so on. No specific serology, but nuclear p-ANCA could be positive. The small duct BSC require liver biopsy for diagnosis. It will give us the characteristic onion peel appearance. The IBD, specifically ulcerative colitis, is present in about 80% to 90% of patients. Usually they have backwash ileitis with rectal sparing. And the guidelines suggest annual colonoscopy for patients with primary sclerosing cholangitis with annual ultrasound screening for biliary malignancy. The treatment, we could start with orthodeoxycholic acid.
النت عندك فصلت يا سامح.
لا في صوت خالص.
لا فصل خالص.
هو كفايه كده. هو اي كلام حلو كفايه.
اديله فرصه 3 دقايق.
ماشي يا باشا.
دي مشكله النت.
النت عنده صعبه.
لا النت في حتت كتير صعبه.
والمطره نازله بترخ.
سامح.
هو انسحب خالص.
هيعمل ري كونكشن تاني.
وحضرتك ناقش الموضوع، ما انت عم الجميع.
الله يخليك.
لا هو في سؤال يا بيه.
قول يا فتح الله.
الحاله اللي كنا عرضناها مره لو حضرتك تفتكر، اللي كان فيها كوليستيزيس واب تو ليفر بايوبسي وطلعت كوليستيزيس وكله نيجاتيف. هاو تو مانج كيس؟
I think we have to have an MRCP picture for this patient. We have experience with cases of primary biliary cirrhosis, some cases, and cases of primary sclerosing cholangitis. In patients with primary biliary cirrhosis, usually we see the pattern of Brundy tree appearance. This characteristic for primary biliary cirrhosis. And for primary sclerosing cholangitis, it's the pattern of beading and strictures at the extrahepatic ducts and intrahepatic ducts. I think in such cases, we see many cases which are very perplexing for us, especially in drug-induced cholestasis. It's very difficult even to take biopsy in these patients. And I think that we may try to give these patients doses of steroids in a trial to alleviate this cholestasis. It's a sort of cholangiolitis. which may be very difficult, and even in some cases, if it is a sort of ductopenia or duct vanishing syndrome, like occurs in some cases with idiosyncrasy to drugs, it may proceed for hepatorenal failure. It's difficult in some situations to have patient with severe cholestasis and unclear etiology. انت معانا يا سامح؟ سامح.
بروفيسور يسري.
ايوه يا احمد.
سامح دخل ولا؟
ما هو معلق، هو مش عارف يخش.
بيدخل.
طيب I would like to
Yes.
I would like
to solve this problem of internet and variations. You know, last month we solved it by making a center for transmission. Those who have weak internet at home can come
Yes.
to the center and broadcast from there. That's the most sure thing.
I think so.
The net is not stable.
Yes. Especially Ahmed. عايز تقول ايه يا احمد؟
regarding patients with intrahepatic cholestasis without identified etiology.
Yes.
You have to identify all etiologies of cholestasis. We have so many causes of cholestasis. So we have to identify the etiologies. And in patients with progressive cholestasis, we don't have too much time to lose. So we have to investigate as early as possible. And for me, we in our unit, we do all investigations in a very short time. Why? Because some patients may have progressive cholestasis and pass into liver failure. Also in some patients, especially immune compromised patients, don't forget to assess for hepatitis C and B virus by PCR, not antibodies. Also Epstein-Barr virus and cytomegalovirus. Even in non-compromised patients, we have to search for them, especially in patients with progressive cholestasis. And myself, in the last year, I have two cases. One of them was CMV, and the other was Epstein-Barr virus in non-immune compromised patient, and one patient was alcoholic. One was alcoholic, and the other was non-immune compromised. So investigations for all causes, including CMV, Epstein-Barr, PCR for hepatitis C and B, and all MRCP to exclude BBC and BSC. And if you didn't find any etiology, we can start empirical corticosteroid therapy in some patients. Some patients may get benefit from corticosteroids with regression of cholestasis.
Yes.
Well, I would like to say something very important in that respect. That intrahepatic cholestasis, the gold standard in the diagnosis is liver biopsy. If you can't do any liver biopsy, then it is usually, in most cases, drug-induced cholestasis. We are using so many drugs nowadays, anti-diabetic, anti-hypertensive, and so on. And in most cases, I see usually في النهاية they are drug-induced hepatitis, cholestasis.
Sameh, can you tell us about specifications in histopathology and liver biopsy of drug-induced cholestasis?
Actually, liver biopsy and drug-induced
علينا مسامح بقى.
I have internet connection problem. Sorry for that.
يلا قول.
Because the drugs have many mechanisms. It can be idiosyncrasy. It can be direct cytopathic effect of the drug itself. It can show some granulomas. There may be cholestatic pattern of bile duct injury. So we cannot say specific features to define drug-induced. It depends on the type of the drug and the exclusion of other causes.
Yes. I think that
أيوة.
اتفضل.
أنا عايز بس أقول للدكتور سامح إن he was very good and your presentation, Dr. Sameh, was very nice and interesting. And we are very sorry for the interruption in the last 2 minutes. But this will not decrease at all your big effort. And I'm very proud to attend your lecture.
Thank you very much, Professor Siraj.
حاجة تانية دكتور طاهر بيه دكتور يوسف بيه the overlap.
Yes,
I mean
the overlap.
ده مش كده.
Yes.
Cholestasis, medical cholestasis, and you find associated common bile duct stone.
Yeah.
Sometimes you have to do
misdiagnosis
or MRCP to see if there is stone or not. And sometimes the MRCP and abdominal ultrasound say no dilated intrahepatic and no stones, and you do ERCP, Ahmed Yazid, and you find the stone. You remove the stone, state cholestasis increases. When you fail everywhere, you start corticosteroids. I second your opinion or your recommendation, Ahmed. Yeah. Corticosteroids sometimes the last. When في الآخر you find it malignancy.
Yes.
يعني overlap.
Yes, overlap is a problem. Sameh, can you tell us about the overlap syndrome?
The overlap syndrome is a medical term which describes the presence of two or more of the autoimmune liver diseases, such as autoimmune hepatitis, primary biliary cholangitis, or primary biliary cirrhosis. Up till now, there is no definite criteria for diagnosis, but suggested criteria by the EASL 2009 and 2017 suppose that the patient should have 2 of 3 diagnostic criteria of each disease. That is to say, 2 of 3 diagnostic criteria of autoimmune hepatitis plus 2 of 3 of diagnostic criteria, for example, of primary biliary cholangitis. And the same applies to primary primary sclerosing cholangitis. The treatment usually in this situation involves the treatment of both conditions. Immunosuppressive therapy is the mainstay, plus orthodeoxyfolic acid, and finally liver transplantation, especially if the patient have advanced cirrhosis or cases like PSC.
Sometimes you need to have a look on the pattern of the bile ducts by MRCP. You find it very, very important in these cases to differentiate between primary biliary cholangitis, primary sclerosing cholangitis, and autoimmune hepatitis, besides the liver biopsy data, because in all of these patients, you find chronic active liver disease, and you cannot differentiate between both except by having MRCP or cholangiographic pattern in such cases. It is very helpful, actually, in many cases. Thank you very much, Professor Sameh, for your elegant presentation. And we'll move to Professor Ibrahim Abdelkader from Al-Manufia University. Professor Ibrahim.
Dr. Yusri Bey.
Professor Ibrahim, congratulations for being the head of transplant unit at Al-Manufia Liver Institute. دكتور ابراهيم دلوقتي اصبح رئيس وحده زراعه الكبد في معهد الكبد بالمنوفيه.
هو العميد عامل له دعايه في الفيسبوك.
لا هي رئيس قسم الجراحه ومدير الوحده الاثنين.
رئيس قسم الجراحه حاليا يعني ده فوق رئاسه قسم الجراحه.
هو شبع بالدايم اعلن هذا امبارح.
ايوه بالظبط.
بروفيسور Yes, Professor Ibrahim will give us Professor Ibrahim will give us a lecture about congenital biliary atresia, about its diagnosis and management. And I'm sure that the Liver Institute have a good experience with managing many cases of biliary atresia, and they have good experience, even before introduction of liver transplantation in the institute. Professor Ibrahim, go ahead.
كده واضحة بيه؟
اوكي.
كده واضحة؟
تمام.
تمام.
ابتدي
بسم الله الرحمن الرحيم. طبعا I would like to thank بروفيسور يسري وبروفيسور حلمي أباظة على الانفيتيشن ديت، وإن شاء الله المرة الجاية كده نكون قاعدين مع بعض في الميتنج روم في اسكندرية زي كل سنة إن شاء الله. حبيت أن أحط I would like to put this slide because
Professor Ibrahim
is a neonatal cholestasis.
Professor Ibrahim, I hope that you keep in English because we have some international viewers asking to speak in English.
Okay. This photo means that neonatal cholestasis or congenital biliary atresia has a very narrow window for cure, especially if you have to treat it before within 2 to 3 months only. Objective of my presentation is awareness about the cause of surgical neonatal jaundice, awareness of what's the clinical picture of biliary atresia, what's the familial method of investigation, what's the management options, and surgical outcome and the result. By definition, biliary atresia is obstructive fibro-inflammatory colon obesity affecting infant may involve in all portion of extrahepatic biliary system, cause progressive obstruction of biliary tree, linked to cholestasis, cirrhosis, ultimately death within first several early years of life if left untreated. It's progressive obliterative cholangiopathy. Incidence, it may be occur 1 to 10,000 or 1 to 15,000. Biliary affect more girls than boys. Asian American is more common. Biliary in them, more common Chinese and Japanese. High index of suspicious is important to make a diagnosis of biliary because surgical treatment by age 2 months has clearly been shown to be improve the outcome and establishment of bile flow and prevent development of biliary cirrhosis. To think about biliary, you have to know the types, most important. There's 3 types of biliary. Type 1 is called distal biliary, affecting the only cone bile duct, whose gallbladder and hepatic duct remain patent. Type 2 is called proximal biliary, classified in type 1 A or B. Type is the hepatic duct is atretic, but proximal interhepatic duct remain patent, may be form of cystic structure within the porta hepatis will be to P is gallbladder, common bile duct, hepatic duct, all obliterated. Only small part of extrahepatic part is patent. These two types called incomplete biliary or correctable biliary. Another, the third type is called complete or incorrectable. Unfortunately, it is most common. It's obliteration of the post-proximal and the distal intrahepatic and extrahepatic biliary. It's a neonatal malformation, can be occur most common with biliary. It's 10% of the case we have, it's called a syndrome. Polysplenia, situs emphasis, pre-duodenal portal vein, cardiac anomalies more common, absence or retroperitoneal IVC is very common biliary. Etiology, exact etiology is unknown. Maybe rotavirus, maybe congenital malformation, maybe cytomegalovirus virus, maybe autoimmunity. The cause is still unknown up to now. Presented by within more than 2 weeks. This is different from the physiological jaundice. The baby of biliary get birth normal. After 2 weeks of life, presented by killy color stools, dark urine, hepatomegaly. Many patients are not to produce normal meconium after birth. 50% of patients initiate initial stool are normal appearing with development of the chelic stool several weeks later. As biliary obstruction become progressively worse. You have to differentiate neonatal cholestasis from cholestatic cyst, colloidal cyst, cystic fibrosis, metabolic disorder like alpha-1 antitrypsin deficiency, water infection, and others. If you're facing the patient with biliary or baby with biliary within after birth, after 2 weeks, you have to look for lab test bilirubin, mainly direct hyperbilirubinemia. High index of suspicion should be put in your mind if you have baby with direct hyperbilirubinemia high. Alkaline phosphatase GGT is most important, significantly elevated, and liver function test ALT/AST moderately elevated. Ultrasound is a crucial point in diagnosis of biliary. Can get a high suspicion of diagnosis, gallbladder lumen disability called gallbladder ghost. Diameter increase and subcapsular flow. If you go to the gallbladder ghost signs, it's gallbladder ghost It's a rudimentary gallbladder, actually. In the baby with biliary atresia, you have to see the gallbladder very short, atretic, irregular, antilobulated contour. Tissue science. To understand tissue science is this photography. This is a plate of atretic common hepatic duct. This atretic common bile duct is the atretic gallbladder. This triangle is called tissue science. Can be illustrated by this figure. It's a green triangle cord, triangular cord-like structure. Atretic band give us a tissue science, like this one, as a portal vein, right portal vein, right anterior and right posterior, and this is a atretic cord-like structure called tissue science by this diagram. Upper endoscopy should be done for all baby with biliary atresia. We can see no bile detected by endoscopy. Liver biopsy is a crucial but not important because it suggests extra hepatic biliary obstruction only. It can be seen so portal or breaching fibrosis, bile duct proliferation, inflammation, or giant cell hepatitis. More common associated with biliary atresia. But cholangiography, MRCP, HIDA scan, usually not needed nowadays. So the most important or gold standard for diagnosing biliary atresia is intraoperative cholangiography. And many investigation give us clues that this is a biliary atresia, but intraoperative cholangiography is not a biliary atresia. We can see, listen, intraoperative cholangiography, simply we inject the dye inside biliary tree and the should will give us idea about the anatomy. This like this one, and the dye here in the duodenum. So this type 1 biliary atresia, this normal baby, this type 2, this type 3. What's the treatment of biliary atresia? Bottom line, treatment of biliary atresia is liver transplant. Is a definite treatment. However, surgical intervention should be aimed for after diagnosis for intraoperative cholangiogram and management accordingly. There is window for management, yes, especially in correctable type. As I said before, it's type 1 and 2 is correctable, and type 3 is uncorrectable. Type 1, we can do hepatic genostomy direct. Type 2A, we can do hepatico-porto-enterostomy. This. Type 2A and type 3 is uncorrectable. We can do called hepatoportoenterostomy or Kasai operation. It's a bridging operation for liver transplant. Just bridging. It's not a definite treatment. It's just bridging for transplant. When to operate, the goal is to operate before 90 days of life. It's important to note how the ostomy is not contraindication after 90 days of age. There is many studies older children relieved excessive survival rate, supporting use of the procedure if so possible, even older. But our experience, after 90 days, the liver patient get worse and develop ascites. We cannot operate after 90 days. So the late, if you facing the patient with late or neglected biliary atresia with moderate or marked fibrosis and ascites, proceed direct to liver transplant. Kasai, what's called portoenterostomy, is a once biliary atresia is suspected surgical intervention in the form of intraoperative cholangiogram. A Kasai operation is indicated. The procedure is not curative, but ideally does by time until the child can achieve growth and undergo liver transplantation. And consider the number of these patients, even if the Kasai portal has been successful, eventually undergo liver transplant. This is the diagram for Kasai portal enterostomy. This gallbladder bile duct, assume this is bile duct. Here should be the biliary triad as the ultrasound. So dissection this area and do biliary anastomosis. Like this dissection, and at the confluence of portal vein, above the confluence of portal vein, right and the left, and the section, we can see just fibers, very small fibers, and the section sizes fiber and puts the loop of intestine, aiming that if there is proliferating ductules, open by the time open and drain bile ducts. Post-operative course after Kasai procedure, 50 to 60% of patients with isolated biliary atresia will have pigmented stool or colored stool with associated downtrend in the serum bilirubin level, typically within 2 weeks. However, some patients take more time. Half these patients will continue to demonstrate good bile flow and the reversal of jaundice, with a reported native liver survival of approximately 40 to 50 or 30 to 40%, 5 to 10 years respectively. Half these patients will continue to demonstrate good bile flow and reversal of jaundice. Other half will continue to experience liver inflammation, fibrosis, eventual liver cell failure, despite initial good response following hepatic portal enterostomy. Jaundice, growth retardation, symptoms associated with portal hypertension gradually occur in settings of progressive or single liver function. Ultimately, we need liver transplant within few years. On the other hand, some patient does not show good response after Kasai operation within 3 to 6 months, so progressive to liver cell failure necessitating liver transplant within months. What's the criteria to put the patient with biliary atresia in the transplant list of liver transplant? It's recurrent resistant cholangitis, portal hypertension, hepatopulmonary syndrome and pulmonary hypertension, severe pleuritis, nutrition compromise, failure to thrive is more very common in Egyptian patient, and hepatic malignancy maybe occurs. Our experience of National Liver Institute, Monrovia University, in this biliary atresia, we starting the biliary atresia maybe from 30 years ago, but the last cases, 10 cases, we have more than 300 cases of biliary atresia, mostly, unfortunately, the common type is type 3. This is the sure signs or diagnostic criteria or golden standard for diagnosis of biliary atresia is intraoperative angiogram. Type 1 can be demonstrated type 1 biliary atresia, it's type 2 biliary atresia, and this type 3 biliary atresia, nothing here. Also, we have transplant program for pediatric since 2003. We have transplanted in the disease per se, biliary atresia, 36 patients of living donor liver transplant. Of course, in Egypt only we have living donor liver transplant. We have no cadaveric program. So we transplanted 17 cases post-Kasai. Those patients, we did for them Kasai operation or hepatoportal enterostomy, and got worse post-operatively, so both in waiting list, and they did transplant 17 cases, and 19 cases is primary choice for treatment. Definite treatment from the start is primary liver transplant. And fortunately, there is a very good result in pediatric transplant, especially in biliary atresia, if it's not treated by operation. Also, it's much better to do a direct liver transplant instead of doing Kasai, and the patient get worse, and there is a long incision such this can be preclude the liver transplant. So this is our experience with biliary atresia with other anomalies. Is biliary atresia with encephalitis inversus totalis. So you can see here the stomach in the right side and the appendix in the left side. Also called pre-duodenal portal vein. We have more than 20 cases. We have anomalies like this. Is a portal vein here and duodenal. Is so-called pre-duodenal portal vein. Polycythemia very common. It's more than 50 cases. We have a polycythemia. Also, we have this portoenterostomy. You have to look for portal vein and go up to the portal veins fibrous tract called portal bifurcation. It's landmark for the section and to get some ductule in place of the called TC signs or cord-like signs.
We are short of
okay, what 2 slides only. Portocholecystomy type 2A in gallbladder and smooth in the bile duct. Also, we don't forget the called cystic type biliary atresia. We have more than 30 cases cystic type biliary atresia, diagnosed as colloidal cyst and intraoperative. We found it after intraoperative cholangiogram is it a type 2 biliary atresia like this one, and we have intraoperative cholangiogram contrasting to the duodenum type 2 biliary atresia. So cyst is not communicating, and so we dissect the cyst and do portoenterostomy, hepatocolchostomy for this patient. So cyst is not a political cyst, it's called cystic type biliary atresia. Thank you.
Thank you, Professor Ibrahim, for this interesting presentation about biliary atresia. I have one question only about the diagnostic role of MRCP in this pediatric age. Do you find it helpful for you?
MRCP is not helpful, and there's maybe need general anesthesia for baby like 5 kilo or
sure.
So not we not need to do MRCP at all. Only we do the gold standard is intraoperative cholangiogram.
Okay, so the surrogate marker for biliary atresia is the intraoperative finding.
Yes.
But you should have strict criteria to diagnose.
And many patients came from the pediatric department for only intraoperative cholangiogram for diagnostic. Is it biliary atresia or not?
Okay. Dr. Yusri Bey.
Yes, Dr. Saragat.
Dr. Ibrahim, thank you very much for this very nice presentation.
Thank you.
I want to ask about the 36 babies you operated, you and your colleagues, upon 17 post-Kasai and 19 originally liver transplantation. You didn't mention, it is side question about the results, because I know the institute in Menofia is pioneer in liver transplantation. What about the results of this transplantation in children? I really want to know.
Yes, I think the result in this category, especially, it was. I think I don't remember the result, but we have maybe 30 cases alive up to now and follow up with us, and 7 cases maybe died post-operative. Like we have a good result in pediatric, especially in biliary atresia.
36 cases are good number. Did you publish this?
No, we have more than we have up to now 82 number of pediatric. It's the most. We have most common program is pediatric in Egypt. So we have 82.
And you never published. You didn't publish
some
anywhere.
cases, yes.
They have previously many publications about Kasai operation.
Published
for transplantation.
Liver transplantation.
Yes, they are still gathering data about the liver transplantation.
Okay.
Okay.
شكرا يا بيه.
شكرا Dr. Ibrahim for this elegant presentation, and then we move to our guest from Alabama University at Birmingham, Dr. Muhammad Jalal Shuriba.
شريبة ده أخونا وحبيبنا.
Muhammad Shuriba. Muhammad Shuriba from Alabama. He will give an important lecture nowadays. That's nutrition in patients with COVID-19. It's an important issue. All of us would like to know about this. Go ahead, Dr. Shuriba.
Right. Thank you everyone for having me, and it's really a privilege and an honor to be with a group like you. Great talk about biliary atresia. There's something to be proud of. So I am a graduate of Al-Asr Al-Aini, a proud graduate of Cairo University, and I'm a transplant hepatologist at the University of Alabama at Birmingham. A lot of my colleagues in Egypt ask me, where is Birmingham? So Birmingham is in the state of Alabama, there on the US map. And a lot of beautiful beaches and nice scenery, good football teams too. And then most importantly for all of us from Egypt, this gentleman in the center there is Tinsley Harrison. So he's the author of Harrison Principles of Medicine, the famous textbook. So he was the chief of medicine in my university where I'm at now, and the dean of medical school too. So it's really a great place to be at. So Alabama is famous also for having positive rate of COVID testing over 20. And we have a staggering number of patients that we hospitalize every day. In my institution, we take care of over 100 patients daily that have COVID-19. So as you are well aware, this is a global pandemic now, and we'll talk about it from a global perspective first before we get into the details of my talk. So this is caused by the SARS-CoV-2 virus, and it hits the ACE2 receptors. Those receptors are throughout the GI tract, and they are particularly on the cholangiocytes in the liver. So we get a lot of consults in my hospital about patients having cholestasis and some also having hepatocellular injury with COVID-19 infection. The disease have quite a few GI manifestations: anorexia, diarrhea, nausea, vomiting, and abdominal discomfort. And the issue with the disease is that if you look beyond those that are getting sick, is really the burden of poverty and starvation, since we're talking about nutrition today in those patients. But 500 million of the population are going to be pushed to poverty. 130 million are at risk of starvation, and 30 countries, including quite a few in our region there in the Middle East and in Africa, will be having famines to deal with. So food prices are no doubtly going up that interruption in the food supply chain. So we'll talk about COVID-19 and its relationship to malnutrition. So malnutrition predisposes patients to infection with COVID-19. So those that have frailty are at higher risk of getting the illness, and at higher risk also of getting hospitalized and getting put in the ICU for treatment. And then it becomes really more of a vicious circle there, that you would have more malnutrition and more debility and leading to more complications. And that is somewhat reminiscent to our patients that have cirrhosis of the liver. When they have malnutrition, they have higher risk of death and complications from their disease. So how do we approach those patients that have COVID-19 in terms of their nutritional needs? I think there are two main groups to look at. So there is a group of patients that are non-critically ill, and those are the ones that you're treating as an outpatient or in the hospital. So always oral nutrition is the preferred route. And as you know, that maintains the gut barrier and prevents the bacterial translocation, which could make those patients sicker. So start the nutritional supplement early on within the first 2 days if your patient is not meeting the nutritional requirements. So the goal is to provide additional 400 calories per day and additional 30 grams of protein, and plan on continuing that for a while after they recover, 3 months or so. Now, if your patient is unable to take PO for any reason, oral intake, then consider nasogastric tube feeding. That's always a good idea. Sometimes we insist on post-pyloric placement of the feeding tubes, but it's debatable whether this is really useful or not. So even if it's in the stomach, that could do the job very well. I think patients that have delayed gastric emptying or gastroparesis, maybe those will benefit from post-pyloric tube placement. Now, if the patient is critically ill in the ICU, the same principle, try to start early enteral nutrition. We have some of those patients that are on ventilators and quite sick. When you start the feeding, just make sure you start at a low dose, at a low rate. So 10 to 20 ml per hour. That's a very low rate there. And then that is preferred to the continuous feeding. The continuous feeding would be associated probably with more complications like diarrhea and vomiting and so forth. Protein supplements, so those patients need higher dose of protein. They need up to 1.5 gram per kilogram per day. And interestingly, this is what we target to give our patients with cirrhosis of the liver too. We want to give them a high protein diet. I think the prominent thing about this talk is that you can apply those principles to a lot of the sick patients, not necessarily the COVID-19 only. So why is it important to increase the protein intake? It actually improves the survival of the patient. So patients have higher risk of mortality if they have lower protein intake and frailty. And also optimize the glucose control. So whether you have to use an insulin drip or intensive subcutaneous insulin regimen. So this way your staff do not have to go into the room frequently to cover the patient with sliding scale of insulin. Total parenteral nutrition, like anybody that's sick in the hospital, should be your last resort, really. It should be the very last choice. You always want to try the enteral feeding to maintain that gut barrier that we're talking about. Now, this is from the European guidelines, and I find it very helpful. So the top box here takes you first to a principle of checking for malnutrition. And then if you move to the left side of the screen to number 2, optimize the nutritional status for the patient, supplement with vitamins and minerals, and we'll get to talk about that a little bit. And encourage physical activity, very important. And if your patient is not meeting the requirements of nutrition, consider the tube feeding, as we said. Patients that are in the ICU side, those to the right side of the screen there. So those patients may need also nasogastric feeding. And after you intubate the patient, keep them on that nasogastric feed and keep it even after they come off the ventilator, because they may have some issues with dysphagia and may need that type of feeding for a while. Now, what about feeding issues that may arise? So in the ICU, for those patients that are very sick with COVID-19, they require sometimes the prone position that they lay on their stomach. And when you do that, there is an increase in the intra-abdominal pressure. And usually they are highly sedated and on paralytic agents. But in reality, it's unclear if that affects their gastric emptying or not. So it shouldn't be a reason to hold off on the feeding. I think you still want to feed those patients. The key there is start at a low rate, as we discussed before, and try to hold the feeding if you're planning a change in position, at least for 1 hour prior to changing position. Now, there are specific issues that may arise in the ICU also, so, or in general with feeding. So for example, a patient with delayed gastric emptying may experience nausea or vomiting, and you may deal with that with prokinetics like metoclopramide, erythromycin IV, and then use post-pyloric feeding as we discussed before. Abdominal distension may happen and diarrhea, and in those cases you can reduce the rate of the feeding, and you can also shift to a semi-elemental or a pre-digested formula. So those are some of the problems that may arise during feeding of those patients. Now, the next thing is how to address the role of vitamins and supplements in patients that have COVID-19. Every patient will ask you about that. Is it a good idea to take vitamin C? Sure, it's a good antioxidant. It protects against coronavirus in avian models. So in birds, it showed that it can prevent the coronavirus infection. It can reduce the severity and duration of rhinovirus infection. That's the common cold. So that's the premise, that maybe it will have some impact on COVID-19. However, still unclear, and the trials are ongoing now. We actually have some data that was initially impressive, that you could use IV vitamin C in septic shock. But when that was tried on multi-center levels in the US, it did not really show that benefit that was projected in the first study. Zinc is a very good supplement that's important for production of antibodies and white blood cells. And patients that are deficient on zinc, they would have increased levels of TNF alpha, IL-1 and IL-6, those inflammatory mediators. And it does inhibit the replication of the virus in the cell model. So in vitro, it successfully did that. And there are trials that are ongoing now for the use of zinc in COVID-19. Now, the thing to be careful about, if you have someone who's persistently taking zinc every day, they would have a risk of copper deficiency. The two are competitors in the body. So something to be aware of, that patients may develop also GI symptoms and risk of copper deficiency if they take excessive zinc. Vitamin D is more of an immunomodulator agent in the body. It has also an inhibitory effect on the inflammatory markers, and it also inhibits the antigen presenting cells. And vitamin D showed actually in animal model, the vitamin D deficiency showed an increase in the risk of COVID-19 infection. It is unlikely to cause harm, so why not if patients would like to try that? But again, we do not have proven benefit for that yet. Now, supplements and food items are a big deal now. So turmeric is known to us in the GI world because it has some data that it may reduce inflammation in patients with inflammatory bowel disease. Ginger is an anti-inflammatory. Garlic and onions have antimicrobial effect. Beets may improve the oxygenation of the tissues. So I think all of those things are fine to use. And you know, if patients would like to eat healthy and think that that would help prevent COVID-19, sure, why not? So in summary, a few points to take home here. There is a dynamic feedback between frailty and malnutrition and the risk of COVID-19. So those that are malnourished and frail are at higher risk of encountering the disease and having a more severe form of it. The use of vitamins and supplements, still investigational, but low potential for harm. So if patients want to use it, I don't see any harm of doing that. Enteral nutrition is the gold standard for your sick patients, so you can maintain that gut barrier. And tube feeding should be considered if patients are unable to take PO. And I think when we talk about malnutrition and a pandemic that's affecting the entire world, we should look beyond our patients and remember those in our community that are hungry and vulnerable. And I think we do a great job with that, particularly in Egypt, something that I'm proud of. So thank you very much. Those are some of the references that I used for my talk. And as I said, it's an honor and pleasure. I intended to finish early just to open the discussion to learn from your expertise. I am here to learn from you as well. Thank you so much.